So a patient asked us to talk about OMG, but not oh my God. It is ocular myasthenia gravis. Ocular myasthenia gravis differs from GMG, which is generalized myasthenia gravis. So we always have to ask about speaking and swallowing difficulty, generalized weakness, because these are the things that kill people, respiratory difficulty or aspiration. In the ocular form, it's confined to the eyelids, usually variable and fatigable ptosis, and diplopia from any pattern of ophthalmoplegia. What it cannot do is it cannot affect the pupil, it cannot cause proptosis, and it cannot cause pain or perception loss. So those are Lee's P's. We're not allowed to have any of those P's. It has to be confined to the neuromuscular junction. It is a motor disease, and the key and differentiating feature is variable and fatigable, which means it changes from time to time, and sometimes it's when you wake up, it's totally open, but by the end of the day, the lid is closed. We're going to be looking for the Cogan's lid twitch sign, and the Cogan's lid twitch sign is a form of acetylcholine instability. So they look down, the acetylcholine is building up, they look up, and it overshoots, and then the lid falls back down. This is the twitch sign. It can occur spontaneously, where it's twitching by itself. We're going to look for orbicularis weakness. So they close their eyes real tight, and we ask them to close tight, and if we can open them with one finger, they're weak. And enhancement of ptosis. Enhancement is when we lift one lid, ptotic lid, the other lid falls down. That is the Hering's law of equal innervation. We're testing for acetylcholine receptor antibodies, binding, blocking, and modulating. Only 50% sensitivity, but over 95% specificity. So if it's positive, they have it. If it's negative, they could still have it. We'll go to the second line, seronegative. That's MuSK, muscle-specific kinase. And if you still think it, you might do third line testing, which is like LRP4 and other muscle-related antibodies. That's triple seronegative. We're going to do a CT scan of the chest to look for thymoma. If they have a thymoma, take it out. If they just have thymic hyperplasia, you might take it out, and it might make the person better. We usually reserve that for generalized disease. We're going to do a single fiber EMG if you have it, but clinical suspicion is usually what drives the decision-making on ocular myasthenia gravis. And we treat the patient symptomatically with pyridostigmine, mestinon, and steroids. Steroid tends to work better for ocular myasthenia gravis. We need to warn them about generalized myasthenia gravis. If it doesn't happen in the first 2 years, it's a lot less likely to happen, but they have a lifelong risk of becoming generalized myasthenia. So you should be thinking about ocular myasthenia gravis in any variable and fatigable combination of ptosis, diplopia, or both. Remember, it's neuromuscular junction motor only. That means no pain, no perception loss, no paresthesia, and no pupil involvement. You're going to do the laboratory tests, but they have terrible sensitivity, although they have high specificity. CT the chest for thymoma, do the Cogan's lid twitch sign, look for enhancement, and then treat the patient in conjunction with neurology and watch out for generalized myasthenia.